All right, good. So we're going to move on to the next sort of part of this discussion. And just to preface this, to say that everything I'm going to talk about in this next hour or so obviously could not be possible without the great work of Sarah and Natasha, and also without all of you, or those of you that have participated. So again, a huge thanks to everybody. So I just wanted to show this picture again because I think, as many of you appreciate, there is an incredible amount of variability in both the behavioral issues and the intellectual disability in your children. So what I'm going to do is give you an update on some fairly recent developments. First of all, on some potential gene-based medical therapies. That's not to say this is gene therapy. We're not going in and fixing DNA yet, but it's rather to use a medication that compensates for the loss of the function of one of the genes that I'll talk about. And then I'll spend a few minutes also talking about nothing quite as elegant as a gene-based therapy, but at least one medical therapy that, for reasons we don't understand mechanistically, may have some benefit for some of your children. So I think it's really important because, as you've already heard, IQ is just one test. We have all these semi-objective criteria for the behavioral issues like ADHD and autism, but what I hope you'll get out of this is that the real goal here is not to change your child's personality, because all of your children are beautiful people, and I think I've heard and experienced firsthand so many great examples of how our children, your children, have enriched our lives. So the purpose is not to change your child as far as who they are as a person, but I would have to say that as a parent myself, one of the most basic goals that we have is for our children to grow up to live independently. And I can tell you that I get contacted pretty often, particularly by families in which their child has been recently diagnosed, just like a month or two ago. And based on the data that you've seen, and I'll show you again in a little bit, I try to be very candid and honest with the families. So recently there was a family that contacted me the day after their child had been diagnosed with a big deletion. And it's gut-wrenching to have to, based on I think some good evidence data that we have now, tell the family, who like all of you or many of you have been through, to burst their bubble to say, well, realistically your child has a 12.5 megabase deletion, and at this point it's not realistic to expect that their child is going to grow up to live independently. So I just want to hopefully make sure all of you understand where I'm coming from with this moving forward. So the goals have been to use approaches similar to what I talked about yesterday for the cardiac gene and what you've already seen somewhat in the last talks, and that is to use this technology to map these deletion breakpoints, and thanks to, again, Sarah and Natasha, to basically identify what the problems are clinically, or the phenotype, and then using all this information to identify potential genes that we identify as what we call candidate genes. And then we can actually, believe it or not, turn to animal models, knowing the limitations, to learn more about what the function of these genes are, and hopefully to go back ultimately to apply that knowledge to develop therapies that can help your children. So you've seen this picture already. This is his chromosome, and again, it's a big loss in his case. And we've used this technology, the ArrayCGH, to, again, make this correlation between deletion size and these various aspects of cognitive function or behavior. And I'm not going to spend any time on this slide because, first of all, I'll embarrass myself, and secondly, you've heard a very elegant discussion about the general standardized testing that we've been using. So what I want to do is just kind of summarize our findings. Again, a lot of this you've already heard. But not too surprising, the systematic testing has borne out what we suspected, and that is there is a wide range of intellectual ability, or wide range of intellectual disability, from near normal to pretty significantly impaired. And most of the time, but not always, and that's important, coming back to Nigel's question about posting this on the internet, because I'm a little concerned, because there are always exceptions, but nonetheless, there is a pretty strong correlation between deletion size and the degree of intellectual disability. And I'm going to show you in a second a diagram that's pretty complex, but it illustrates how we have been able to identify at least 4 different regions that your children may or may not have deleted that we think contribute to the overall intellectual disability and or behavioral problems. And one of them I'm going to tell you about in particular is an area that contains the gene that we think is responsible for why any child that has a deletion beyond 12 megabases, so that's what I use to classify as a so-called large deletion. I'm going to tell you about a gene that's right in that area that we think is the cause for the more significant intellectual disability in the children with large deletions. So this is a very kind of busy picture illustrating what we've seen before. So this top is just a cartoon line showing the end of chromosome 11, so TEL stands for telomere, or the end of that chromosome. Oops. And what we have identified is probably at least 4 different locations within this region, from the end up until pretty far up, that contain a putative gene or genes that we think contribute to the intellectual disability and or behavioral problems. So intuitively, and I'll show you more in a moment, if you have the largest deletion that spans these 4 regions, you're going to be the most significantly impaired. And the region I was just telling you about, I call here region 1, that contains this one gene. Now, interestingly, what I've shown here by these little smaller horizontal lines is reflecting patients that have cognitive and or behavioral problems that instead of having a big deletion that goes out to the end, has what we refer to as these smaller interstitial deletions, so deletions within the chromosome. And what we've been able to see through some very rare patients is that if you, for example, have either any of these individual 4 regions deleted just by themselves, so for these regions 1, 2, and 3, if you just have one of those 3 deletions, then you're relatively mildly impaired in terms of standardized testing. Similarly, if you have a very small deletion that just is at the end, you are also relatively mildly impaired. If you have a deletion that involves this region 1 plus any of the other regions, so 1 plus 2, 1 plus 2 plus 3, or 1 plus 2 plus 3 plus 4, you're pretty significantly impaired. So there's something we think within this region 1 that really is sort of the culprit that's responsible for causing the more significant intellectual disability. And again, if you have a deletion that goes out from the end up to this region 3, you're going to be relatively mildly impaired, maybe slightly more impaired if that deletion goes through and across region 2. But then there's a very clear line of demarcation such that when you go past and to include this deletion 1, that's when you're going to have the most significant impairment. Does that make sense? Does anybody have any questions about that? Go ahead. Yes. About 124, yeah. Yep. Okay, did everyone hear the question? So the end of the chromosome is like a mileage marker, and the number you'll see is about 135 million. So in other words, from the very beginning of the chromosome to the end of 11q, that number is about 135 million. It's literally just like a mileage marker on a highway. And that's how we map these deletions using that erase-CGH technology. Any other questions about that? Okay, so moving forward, what you've heard already, and this is just another way of saying it, and that is based on now 10 plus years of testing, we can say that without exception, if you have a deletion that is in that large range that goes past that region 1 that I told you about, once we can do a rigorous enough test, meaning from about age 5, those children are pretty significantly impaired. So in other words, anybody who has a terminal deletion greater than 12 megabases, without exception, for probably 30 to 40 patients now, children that we've assessed, have the most significant impairment. And this is just another way of showing the same thing. So the bar graph here shows that the smallest deletions on average have a full-scale IQ of about 75. The medium-sized deletions on average have an IQ of about 65. And then once you get into that region 1, you have a really pretty precipitous drop where that full-scale IQ scores into the 40s. So now, with that information, using the genomics information from the Human Genome Sequencing Project, we could look at what genes might be in that specific region 1, and this is just kind of a busy way of showing something that you've basically already seen before. And going from your right is kind of towards the end of the chromosome, and what I'm showing here is, here's the patient, if you can see my arrow, who has a deletion that ends just before that first region that I referred to. So that deletion is just less than 12 megabases. And then if you take a slightly bigger deletion, that's just over 12 megabases, what we have here in that very small region is just a few genes. And there's one gene that I'm going to tell you about now called BSX1. And kind of pleasing for what we're interested in, that gene has actually the name brain in its name. So brain homeobox protein is the formal name of the BSX1 gene. So it turns out there's one group in the whole world that's been studying this gene, a guy that some of you may know of, Matthias Trier, who is a PhD neurobiologist based in Berlin. And Matthias has done some really, really elegant work on what this gene does. And I should say that prior to my contacting him about this, he had no idea that actually BSX1 may have a role in cognitive function. What Matthias has very elegantly studied and shown is that BSX1 serves as like a molecular switch in the brain to regulate appetite and sleep. And what he thinks, based on some, again, really exciting research that he's been doing, is that he's shown that this BSX1 protein is actually found in a small subset of neurons in the brain. And at least in my simplistic terms, what he thinks is going on is that BSX1 normally keeps areas of the brain that are involved in at least some aspects of cognitive function awake. And so when I first contacted Matthias, he has the knockout mice, like what you've heard for the other work that we're doing. And he had never done this before for this gene, but I asked him, why don't you go back and look at the intellectual ability of your mice that are missing this gene? And in fact, they had a dramatic reduction in their intellectual ability. So they were severely intellectually impaired, and that was very gratifying in order to help us to confirm our suspicions from the human genetics that this gene may be really having a critical role in intellectual function. And I'm not going to go into the details in terms of the biochemistry of how this protein regulates this signaling pathway, but what Matthias, and this is totally his thinking, was able to find, or is hypothesizing, is that there is a commonly used FDA drug that may restore the loss of one copy of this gene to boost the function of that protein back up to near normal levels. And interestingly, that drug is a drug called Modafinil. Any of you heard of this drug? So Modafinil has been used with FDA approval for treating, interestingly, narcolepsy. So narcolepsy is that disease that you hear about where I can be talking to you and then in the middle of the day I just fall asleep right on the spot. It's also been used to treat anxiety. And it was really interesting. I actually did just a Google search, and really, coincidentally or not, it's actually been used. I don't know why people would do this. Well, I do, but some people use this to make themselves feel smarter, believe it or not. Of course, they have no idea how it's working. And so when you put all this together, it suggests the very interesting possibility that treatment with Modafinil could help your children that have this largest deletion that involves the BSX1 gene. And so what we want to do is try what we would consider an off-label use, so we don't have to go through the FDA to get approval again because it's already been shown to be safe. And so we're in the process of getting ready to start a couple of children that have a large deletion with significant intellectual disability on Modafinil. And we're hoping that we can get the result that we want, that this drug may help to improve the intellectual disability and anxiety. And actually, literally just today, after starting this about 12 years ago, one of the people that has been at this conference today, this week, is going to be seeing my colleague over at UCSD, a behavioral pediatrician who works with Dr. Marty Stein, who is going to start him on Modafinil, literally starting today. So this is a huge step forward. The good news about Modafinil, because I'm sure many of you will be wanting to know, is that if taken properly, it's a very safe drug. So literally starting today, we will hopefully in the near future get some preliminary answers. So you've seen this slide. This is Robin Olney. And as I mentioned in my talk yesterday, she was the first person that was brought to my attention with Jacobsen syndrome that carried the diagnosis of autism. And she was diagnosed through a whole battery of very sophisticated testing, I believe at that time at a center in Belgium. And so here we go again with one of these kinds of figures that you already saw in the previous talk. And suffice it to say that just like I showed you before, we could then narrow down a common region of overlap to determine whether or not there might be an interesting gene residing in that region that could be responsible for causing autism, at least one gene. And this is a blow-up just like what you saw before, and it turns out there's, again, in this very tiny region of overlap, just a few genes, and one in particular is a gene that already has been known to have a very critical role in brain function. And that gene is called RIX, which I can't even remember what it stands for, some huge long name, or ARCHGAP32. So again, kind of analogous to the story I just told you about BSX1, there's actually only one group in the world that happens to be studying this gene, a group of neuroscientists that are in Tokyo. And it turned out when this all kind of came to the forefront several years ago, I happened to be on my way to Tokyo for a cardiac development conference, and so I was able to hook up with these investigators. And again, they were very excited because they had never suspected that after having done all this work already on what this gene does in brain development, they had never suspected the possibility that this protein may have some role in autism. So when I met with them in Tokyo, I challenged them if they were interested with two questions. One, they had knockout mice, but they had never tested their knockout mice to determine if they have any kind of autistic-like features. And then the second question I posed to them is, based on all this elegant biochemistry that they have worked out, could there be a potential target for a drug therapy? So this is an example of some of the testing that they can do in mice to assess for some aspects of autistic-like behavior. So on the left is just a normal, quote-unquote, wild type or control mouse. And you see all these little black marbles in the shavings. And they're all lined up. And the normal mouse on the left is just kind of doing his own thing. Once in a while, he'll stand up and look around, curious about his surroundings. And if you look at the mouse on the right, this is a mouse now that's missing both copies of this RIX gene. And I think what you'll appreciate, again, this is just one aspect. This is a mouse. This is obviously not a human. But you could begin to appreciate some repetitive digging behaviors that this mouse on the right is doing, much more so than the mouse on the left. And in fact, they can quantify this. And what you see here is the green is the normal control. Actually, sorry, the blue is the normal control. And what you see is even with one copy missing, compared to the normal mouse on the left, the mouse on the right that's missing either one or two copies of the gene has buried a lot more of their marbles, which is a way to quantify that kind of repetitive digging behavior. So that's just one aspect of autism. There are obviously much more complex behaviors. Some can and some can't be measured in a mouse. One of them that is used as sort of a parameter for social function is the ability to smell and respond to certain olfactory cues. And similarly, what they were able to show is, first of all, these mice all have a normal sense of smell, but when you challenge them with social smells, like with a piece of something that's immersed with the smell of another fellow mouse, normally a mouse that has normal social interactions will be very attracted to the smell. And I'm not going to bog you down with all the details, but suffice it to say here that even if you're missing one copy of this gene, they seem to have much less interest in going after this scent that is sort of a indicator of social interest or social behavior, and even more so when they're missing both genes. So I think, and that's just a little bit of the tip of the iceberg, but they were very convincingly able to then answer the first question that I posed to them, and that is, that loss of 1 or 2 copies of this gene in a mouse gives the mouse version of at least some autistic behaviors. And so the second question that I pose again is, through the biochemistry that they worked out for what this protein actually does, could there be a drug that could target whatever this problem is? And don't worry, this is a very, very busy slide. All I'm going to show you is this blue oval here is a depiction of this RIX protein. And it turns out what this RIX protein does is to sort of anchor and stabilize a receptor on the surface of neurons in the brain that's actually critical for signaling inhibitory pathways. And I'm not a neuroscientist, but one of the prevailing theories, and Natasha, please correct me, but one of the prevailing theories about autism is it requires a balance in the neuronal signaling between inhibition and stimulation. And the thought is that if you have some perturbation of this balance, that might result in autistic-like features. Do you want to add anything to that, Natasha? Okay. That is from a non-neurobiologist. So what they did then is knowing what the pharmacology is of this receptor, they were able to hypothesize that it turns out a very well-known drug that's been used to treat anxiety called clonazepam may in fact help to compensate for the loss of 1 copy of that protein, like actually most of your children have. And remarkably, what they found is that treatment of these mice that are missing 1 copy of clonazepam actually resulted in a dramatic improvement in some of those things that I just showed you. So I want to move on now to where we're going with this. And I showed you this young man yesterday. This is Carlos. And I want to tell you a little bit about Carlos. And this is, I think, a great tribute to whether or not you like Facebook, but I learned about Facebook because Carlos's dad posted on Facebook a couple years ago that his son had just been diagnosed with Jacobsen syndrome, and he had pretty severe autism. So I got pretty obviously interested. I was lucky that I happened to be looking at Facebook that day. And actually, Carlos does not have Jacobsen syndrome. But what Carlos does have is, as shown here, a very, very tiny deletion in that region that happens to span the RIX gene and a couple other genes that are probably irrelevant in terms of autism. And so it's been quite a process over the last 2 years to get to the point where we could ask the question formally, might Carlos respond to treatment with clonazepam? And so history was made in February, and Carlos was the first child that we have treated prospectively with clonazepam, i.e. a specific gene-based therapy. So Carlos and his family came out to San Diego first. They were here at the last conference, and then more recently this past February to undergo a comprehensive assessment by our colleague, Dr. Liu, who is a behavioral pediatrician here at UCSD. And this is sort of a summary of what Dr. Liu came up with in assessing Carlos. So Carlos is nonverbal, autistic, and has very significant self-injurious behaviors, which are concerning to his parents. He also has some symptoms of anxiety and hyperactivity. So, how many of you have had these kinds of problems with your children? I imagine quite a few. I already know the answer to that. All right, so then he was started on low-dose clonazepam, and that's a really important point, because one of the problems with this class of drugs is that oftentimes to get a therapeutic response, a negative side effect is that your child is made into a zombie because of all the sedating effects. So just like in the mice, Carlos was started deliberately on a very low dose to avoid any kind of sedation side effects. And I'm just going to read you Dr. Liu's initial assessment 2 months into treatment. So since initiation of low-dose clonazepam, Carlos has had a significant decrease in his self-injurious behaviors, and his father reports that he appears happier and calmer as well. He is pleased with the benefit from the medication and states that he has not observed any side effects. Carlos has been making progress with his communication at school, and per his teacher, his behaviors were improved at school as well. Carlos has been noted to have some increased activity where he has been getting into things around his home, and his father would like to address the problems with sleep if at all possible. And so I'd like to ask the Flores family, if they wouldn't mind coming up here and introduce you to Caesar, Dad, and his 3 children. And what I'd like to do is just for a minute or so ask Caesar if he wouldn't mind giving an update and kind of sharing his thoughts about how Carlos was doing before treatment, and again, just to express what he thinks has changed in the last few months. You're going to do it? All right, introduce yourself.
Hi, I'm Haley. I'm Carlos's older sister. And before the medication, he
Are we hearing okay? Make
Do
sure.
you hear? He used to hit himself a lot and scratch himself. And he would scream, he would throw tantrums. You could never get him to calm down. He would take you to wherever he wanted, and if he didn't want it, he would still freak out. Ever since we started the medication, he has stopped hitting himself. He's a lot calmer. He communicates a lot more now. He plays with Caesar, which he never did before. He likes getting chased around. He seems happier. He would just, before the medication, he was just always screaming, and the only thing that would calm him down was a TV or an iPad, and now he likes to run around and play. So the medication has helped a lot.
All right, anything you want to add to that?
And actually, sometimes he still inflicts himself, but it's very minor, though. It's just, we noticed that we've taken the iPad from him for a while, and actually we took it back away from him because it brings too much anxiety to him. He loves to have it, but when it's not working, he gets really, really upset about it. And if it's not moving fast enough, so certain things might trigger it, but we're seeing them and removing them from the place, or trying to help him out. But he's doing good. I mean, he's been sitting here for like, what, an hour already?
Yeah.
And he's been
Could you have done that
hurt
before?
him. No, sometimes no.
But let me ask you this. Do you feel like the medicine has made him sleepy and a zombie or anything like that?
Oh, not at all. He's still wide awake. He's actually he observes more. He sees more things. He's more aware about his surroundings. So he still has, he's still not perfect, but he's done a lot better.
And actually, Carlos is going to be seeing Dr. Liu this afternoon for the 4-month follow-up. So it's a work in progress, but thank you. Thanks. That's great. And I just want to say this family is incredible. We've literally been trying first to get him initially evaluated down there in Houston, but things kept becoming problematic. And finally I said, the hell with it. We're just going to fly you up here and do this properly up here. And, the Flores family has been so patient and supportive. And just so you know, what you guys have been doing stands to benefit potentially a lot of the families in this room and throughout the world. So that is huge. Yes, Jessica. Yeah, let me show you the next slide. How's that? Good prompt. I'd have to go back and look. It's about 9 megabases, I think, up from the end. So basically, most of your children are missing a copy of this gene. So remember what I said, though. Carlos has that tiny deletion. He does not have Jacobsen syndrome, and here's where it gets a little complicated. There's several other genes, or there are potentially a few other genes that your children with Jacobsen syndrome have deleted that might also cause autism. And so that really begs the question, if you have 3 different genes that your child is missing that can all cause autism, could treatment for one gene-based therapy be effective, or what's going to win out? And so we don't know the answer to that question. I am very hopeful that even if your child has potentially other genes deleted, that the treatment for loss of the RIX gene will sort of win out, but we don't know the answer to that. So what I want to do now, that kind of is where we are in terms of specific gene-based medical therapies. What I want to do now is spend a little bit of time talking about some potential other medical therapies that we don't have a genetic basis for per se, but one in particular may be effective. So I refer to this as an empirical therapy for intellectual disability. And this is Sophia, who many of you know from previous conferences. And as I recall, I think it was Sophia's parents who reached out to me to tell me several years ago that Sophia at the time had been diagnosed with autism, but they did not know yet that she had Jacobsen syndrome. And actually, fortunately, that was great because she was only able to be enrolled in an NIH study in the Midwest, headed by Dr. Shugani, that some of you met in the last couple of conferences. So this is an NIH study to determine whether or not treatment with a specific antidepressant drug called buspirone may help autism. Okay, and so this was published a couple of years ago now, and the upshot of the study was that it did seem to improve one aspect of autism, namely some of the repetitive behaviors, but maybe not as robustly as what we would have hoped for. And in this case, it actually turned out to be very dose-dependent. It turned out only a low dose seemed to have that effect compared to control, but not a higher dose. And there have been other studies that have implicated that the combination maybe of buspirone and the drug called melatonin that I know some of your children and adults take for sleeping problems may be beneficial. So that really begged the question, can buspirone maybe help with autism or other aspects? Well, so Sophia had actually been treated for 6 months with buspirone. And what was very interesting is that, to some disappointment, correct me if I'm wrong, Don, but she didn't really have a dramatic change in her autistic features specifically, but what was noted was that over the 6 months that she was on this medication, she seemed to have a pretty profound response in terms of her daily living skills. So over that 6-month period of time, the way they quantify this, she actually improved by like 2 years. So that was highly compelling, even though we didn't know necessarily the gene responsible. So now I want to tell you, actually what I would like to do is ask Dawn to come up here for a moment and maybe just for, again, a minute or so, share with us some of her observations before and after treatment. I probably completely misrepresented what you told me. So.
No, and I've been trying to remember exactly, because this was a while ago. Sophia just turned 12, and I think it was just before she turned 5 that we started this study. And it was a double-blind study. She was on the 5 milligrams of buspirone. I'm going to say it like that, even though it's not the correct pronunciation.
Yeah, you're from the Midwest.
So anyway, it was a double-blind study, and so before that, Sophia never had self-injurious behavior or anything like that. She was never really like a behavior problem, but she, like, total lack of focus, just kind of like all over the place. Never like sticks with anything for a minute. Like her idea of play would be, walking around and taking everything out of our cabinets, and like she never really like played with toys, never really like stuck with anything for any period of time. So, and she wasn't learning well. She, took her a longer time to start talking and things like that. So we had her in the study. A teacher of hers brought it up to us, and we enrolled her in the study. And the first day we were there, we didn't know if she was on the drug, but I guess I should tell you too, before this, she always woke up every night. She would wake up, not with night terrors, but confusional arousals, I think they call it. Every single night, Sophia would wake up probably at least 2 times, 2 to 6 times a night, since the time she was probably about a year old. And she would just wake up, and once she started talking, would say, no, 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 So she wasn't screaming, but every night she'd wake up, and you go up there and calm her down. So this study, she got the drug, or the placebo, we didn't know. On the way home in the car, she fell asleep with her mouth wide open, when she never slept in the car anymore. So it was pretty quickly that we noticed a dramatic difference in her sleep. Like, I want to say, like, the first or second night she had it, they were sleeping on our floor for some reason, her and my son. And she woke up in the middle of the night and said, like, one word, like, door or something. And she laid back down and went to sleep. And, I mean, her sleep was like that afterwards. Like, she just slept. So that was a really big deal. I think maybe that alone could change a person, just getting a good night's sleep every single night. She's always slept well since then. She has. And then the other thing that we noticed a difference in her, and I know this isn't going to be really concrete, but I know for sure that this had a big impact on her, just sticking with things a little bit longer. Just sticking with something a little bit longer, helped her learn, helped her. We went to a little water park place, just, one where they kind of jump through some stuff, not a big deal one. And she was playing with this other girl and just kind of doing the same things she was. The other girl laid down and did something, and she did too. And so again, just kind of sticking with things just a little bit longer and being able to pick up on what other people were doing. It sounds very minor, but that was a major thing. You could see it in everyday life. I mean, that was a part of every day. So a huge difference in her sleep, and then sticking with things a little bit longer. I guess I didn't remember that it was the 2-year difference, but it just made a big difference in her. It just made a huge difference. So I don't have a ton of concrete examples to give you, but I mean, I think sleep alone was worth it. Absolutely no negative side effects from this drug. But I wish we had started her on it when she was 2, because the study was 2 to 6 years old, I think. And I really feel like it would have made a huge difference, because the idea behind the study was supposed to be to help serotonin synthesis, which is kind of like getting the message in your brain, making those connections that the kids with autism aren't. And I feel like it did do that. So again, I don't have concrete evidence for you, but that was our experience. She is still on it. I was hoping Dr. Shigani would be here to ask about that, because I remember they said, so normally kids with autism would stop this at 8. So there was a chart they showed me. So in your brain you have serotonin floating around, and it's used, it's synthesized to create some sort of electrical signal to make neural pathways or something. So in typically developing kids, when they're born, it's like this. The serotonin synthesis is like this, and then it kind of goes down and levels off. And the kids with autism, it was like much lower, and it levels off. So they don't have that when they're born. They don't create all those pathways, and so that's not being used up, and they have all this extra serotonin in their head. So anyway, the levels meet at about age 8. So in this study, they were telling us at age 8 it would make no difference for her. But then when it was discovered that she had Jacobsen's, it's maybe a different mechanism that's working, I don't know. So they said she should continue to take it. But I don't really know for how long, so I hate to quit it because it's still, there's no negative side effects. Yeah, she sleeps.
All right, that's awesome.
So that's it.
Thank you. So she's been on it now for 7 years, right? Okay. All right. Our next star is Kalia that I want to tell you about. Most of you by now know Kalia, one of the 3 families that have been coming here since 1998. Did you figure out the third? It's Tristan, Kalia. Who was the third family? I can't remember. That came to the 1998 conference. Are you here? All right, anyway. So previous testing revealed that Kalia had a full-scale IQ based on whatever limitations of about 50, and she had actually had that assessed multiple times, so that was pretty consistent. And then she was diagnosed previously by her psychiatrist several years ago with autism, using back then sort of the standardized clinical criteria through what's called the Diagnostic Statistical Manual of Psychiatric Diagnoses, so DSM-4. And unbeknownst to me until last year, because Annette had been coming to this conference many times, she conspired with her psychiatrist to start Kalia on clonazepam and buspirone with the hopes of improving maybe some of her cognitive function and or behavioral issues. And so I learned about this really only fairly recently last year, and I was able to talk to her psychiatrist who had been overseeing this therapy. And I'm just going to read you what her psychiatrist told me. Certainly improved since being on both buspirone and clonazepam. Possible improved level of functioning since buspirone was started. By the way, they were not started at the same time. Able to articulate how she feels and process an appropriate reaction and less reactive mood. She states that she's having less outbursts since starting buspirone. She was hitting herself when angry, and she has stopped that. If she has outbursts, it's towards others, not her mom. She's taking clonazepam now, so this was after she was started on clonazepam. And this has helped her mood swings a great deal. She's better able to deal with her anxiety. When she gets upset, it's for a shorter duration. So I'm going to ask Annette to come up here with Kalia, if she'd like, and maybe just briefly give us your insights about before and what you think is different since being started on these medicines.
We started this shortly after our 2012, and I was able to talk to her physicians, and because she had had some of the levels of anxiety, we were able to get in with the clonazepam under that diagnosis, not necessarily for what we wanted to try. So since 2012, well, let me go to prior. Prior to 2012, there was a lot of dependency, a lot of safety supervision issues. She also has seizures, so it was a big deal to have her on her own. Since we started, the daily living skills have improved significantly. She's not needing so many autistic reminders. We went through ABA and had charts on the walls and color-coded duct tape in a shower to show what was conditioner, what was number 1, number 2, number 3, everything from shower soap to shampoo and conditioner. So all of those things were there, and she would move her stickers from one side to another. That's not necessary anymore. And the process that she goes through in the morning to get up and get down doesn't require as many reminders. So the biggest thing is just her daily functioning. So much so that in July of last year, she has, what did you do in July? Where did you move?
I just recently moved to Scotts Valley, and everything's different.
What do you have that you didn't have ever before?
Jacobsen syndrome.
Nope, you have your own.
Oh, my own house and my own room now.
And she has her own 24-hour staff. So she still has supervision, but she's not dependent from a parental standpoint, where, my fears were so heightened that it wasn't ever going to happen, that with the improvements that she's been doing, with significant, large improvements since, July of last year. December of 16, she started a College of Adaptive Arts, and her attention span there has been so significantly improved that she is on a panel in a class, which is an accredited college, actually. So she not only does GE credits, within her abilities, and they work slowly to do that, but they have, adaptive arts as well, that she has written screenplays, participated in them, retained the screen or the script, and been able to put it out, at appropriate timing. And that was huge, because the retention level, let alone being put on the spot with anxiety and, everybody looking at you, it would not have happened. He would have been just kind of shut down, no contact, but to be able to stand up and do public speaking, which she's done 4 times over the course of this curriculum that she started, as well as 3 plays, right? So she did, we didn't do Guys and Dolls, she did Bye Bye Birdie, she did an adaptive screenplay with 3 of her class peers, and then put it on and play, and it was actually reviewed and was performed in a theater in San Jose. So it's a pretty big deal, just the amount of that little bit of help to kind of calm the waves and be able to concentrate on stuff has been huge.
Thank you. That's awesome.
Sorry, Jessica. None. And you would think that there would be, but no, she has an outburst, very controlled, no medical issues, no bleeding issues, no increased infections of any sort. All of that has stayed within her normal realm of her. If she has her issues, but within her norm. So nothing outstanding. She is 30 August 5th this year.
Thank you, Kalia. So when I learned last year that she had been started on these 2 medications, totally unbeknownst to us, I said, we got to get her back down here and do a comprehensive assessment. So that's what we did. Last year, Sarah and Natasha did this. And there were some kind of surprises based on these criteria. One thing that stood out was that really there was no significant change in her full-scale IQ based on how we measure full-scale IQ. But if you look at this battery, all these different parameters, there was one thing that did stick out somewhat that I have to think is not coincidence, but I'm biased myself, and that is, look at down here. Her daily living skills score did have a modest improvement. So, it's retrospective, but it was somewhat encouraging. So just to kind of summarize Kalia's situation, there was really no significant improvement in her full-scale IQ. I think Annette has profoundly said what she thinks has changed in terms of daily living skills, which I think is somewhat borne out. In terms of her autism, she wasn't part of the autism study right before, or at the time that she was diagnosed. So this is kind of retrospective and anecdotal, so we don't really know for sure, but it suggests maybe she's had some improvement in her autistic features. So it's encouraging to me, I think, and hopefully to you. A couple months ago, I think for those of you that follow Facebook, I reached out to see, just without any bias, what medications, if any, your children have been on. And so this is just a little summary of that. Again, this is totally non-scientific, but it was interesting that one drug, for whatever reasons, that on more than one occasion I heard back from people saying seemed to have some benefit, is risperidol. And then some of these others, which may or may not be effective. But we have no science behind that. That's just totally empirical, retrospective, and anecdotal. But I think where we're at now is that for at least 2 of these medications, modafinil and clonazepam, it may lead the way for gene-based therapies. I think buspirone is very encouraging, but N equals 2 at best. So that's also obviously very, very limited, and there may be others. So I'm not going to go over the summary. Just moving forward, to do this properly, we can't just have 1 or 2 anecdotal cases or 1 or 2 prospective cases. We really need to do a proper prospective controlled trial. And I think the best chance for getting funding is going to be for modafinil and clonazepam, because those are gene-based. And the more you know about the mechanism, the more enticing it is to get funding, I think. But I do think that the buspirone therapy is also potentially promising. So that's kind of where we're at. I think we've made some very exciting progress in the last 2 years, but obviously we have a lot more to learn. And again, there have been a ton of people here locally and around the world that have really made this possible. And finally, none of this would be possible without you guys. So thank you again. How are we doing for time? We need to rescue the kids from the... Yeah. Sarah, do you want to come up here too? Did Natasha have to leave? Okay, why don't you come up here, because I'm sure you can answer most of these questions far better than me. Oh, yeah.
Hi again. The BSX gene that the modafinil was, where is that gene?
So that's 12 megabases up, so that's higher up.
So if you're not missing that gene,
Right.
that wouldn't be effective,
Correct.
probably. And similar to, like, say, a growth hormone where there is a window, do you suspect that there is a window for these drugs?
That's a great question, and
I know you don't know for sure, but
hypothetically, for modafinil, it's signaling. It's like an on-off switch for a light.
okay,
So in theory, one would hypothesize that that could be effective at any age, in
Okay.
theory. Now, maybe the light switch goes bad, so you can never turn it back on.
Right.
As you get older, that all remain, that's a huge reason why we need to do a prospective study
right.
for people at different ages.
And do you think that if someone took this medication for a short time, that the benefits would extend beyond?
It's
like-
another reason why we need
Okay.
to do a study, because based on the mechanism, I would think that it's a signal. It's a chemical, basically. And so you're going to need to keep
Taking it.
bolstering, to keep taking it to maintain that signaling
Okay.
level. I don't think it would be a one-time and then you're cured.
Okay, thank you.
Marie on the stream says Dylan's been on dexamphetamine for almost 12 months and has improved in all areas. He's calmer, more focused on tasks, and his behaviors have improved enormously.
So that's an ADHD drug, one of the typical stimulants that's used. And I've heard mixed responses from families with Jacobsen syndrome children about whether or not they improve on the ADHD drugs, typically like Ritalin.
Forgive me if this has been spoken of. I've been working with the kids.
You're forgiven.
Thank you.
And thanks.
Thank you for that. Regarding having doctors take the initiative, most of our providers will not prescribe anything that
Right.
hasn't been sufficiently researched.
Right.
And what would you recommend? Would you suggest that we put them in contact with you, that we provide any of the studies that have been presented? And then my next concern would be insurance providers who
Right.
take the same. Has anybody had any success with that? And
Well, yeah, these are great questions. So, this is why I was actually, in some ways, very reluctant to even give this talk, because I don't think we're at the point yet where you should all run off to your caretakers, your physicians, and say, well, Grossfeld just gave this talk with these families. These are the magic bullets to help my child. We're not there yet.
Okay.
And to be honest, unless it's some extraordinary situation, let's just say where your child was doing horrific injury to themselves or others, maybe on a compassionate care basis. But short of that, what we really have to do is a prospective study to have evidence base. I mean, this is, tantalizing, but it's very, very early on. And so I think we really need to do the hardcore clinical study to really validate this. In terms of insurance, that also is a challenge. I think it would be hard for insurance to cover it at this point when it's an off-label use. However, for modafinil, modafinil has been used, correct me if I'm wrong, Sarah, for anxiety, and so you could probably, work the system a little bit to say they're being treated for anxiety when that's only part of it. So
And I can just speak
I
a
hope
little.
there are no insurance people.
I can just speak a little encouragement when in the fall we were at the point where we were going to consider risperidol, and by pushing through with, as resentful as we were to the providers at that time, pushing through some things and doing some really intensive behavior therapy, as exhausting and draining as it was for us all, we have a different child, and it took 3 to 5 months. But just to give people some hope if they're in that place, even though there's still a lot of presenting symptoms that I feel like the Wellbutrin, or the Buspirone, Buspar,
Yeah.
would assist our child with. So are there things we can do to engage and support in the studies with our kids? Will you contact us?
We need money.
Okay.
It's really that simple.
So that comes on Thursday as
need
we work
funding.
on fundraising,
So
supporting
everybody
youth
come back
fundraising.
Thursday morning. What time is it, 9:30?
Yeah.
And seriously, I mean, we can't do this without resources. I can't expect Sarah to give up every day to do this, or the person who's meeting this afternoon with 2 of the people from this group. So
So you need
we've
us to
got
partner
have
with you.
Funding. And we're not talking, the beauty of this in terms of a funding issue is that I think if we're going to see responses, we're going to see them pretty early on, like you've heard. And so it's not like we have to treat these kids for 5 years and follow them. I mean, we would like to ideally, but at least as an initial proof of concept, I think we could treat them for a relatively short period of time to determine whether or not it's going to be effective. So that's huge in terms of dollars needed. Any other questions? All right. I think we can stop.